Welcome to Civil Discourse, a podcast where participants are free to share their ideas, empathize with other perspectives, and who intend to advance to a better solution to fix a societal ill. We will focus on topics that are particularly complicated. In a time where information is from sources more opinionated than ever, our mission is to find solutions and goals to accelerate the nation's progress with cultural impunity. I'm your host, Todd Furniss. Well, welcome. We have today as our guest, John Goodman, Dr. John Goodman, a very renowned economist who has done a lot of work in public policy. And we're going to try and tap into his wealth of knowledge with regard specifically to healthcare economics and some of the issues associated with the way that the healthcare industry works. John, good morning to you, and thank you so much for joining us today.
Well, glad to be with you.
So just a little bit about your credentials. You studied at UT and then you went on to Columbia to get your doctorate degree. Have that largely correct and directionally correct?
Well, that's correct. I got my PhD from Columbia, then I went to Stanford, then I went to Dartmouth, and had a fiance back in Dallas. That's why I really moved back to Texas.
Well, we're glad you came. You published over 15 books, had over 50 studies published. So it'd be fair to say that you are you're at least well-read and well-published. I think I'd call you an expert in the field. But for our purposes today, one of the things that you did, there are two big issues I think that you really have contributed handsomely to in the field of healthcare. One is the concept of the importance of consumerism. And secondly, arming Americans with money so that they can be consumers in the form of HSAs. So I'd like to kind of talk a little bit about that, if we may. Talk a little bit about consumerism, if you would, and why you think that's important.
Well, these things go together. And the idea of the health savings accounts is that people should be able to manage some of their own healthcare dollars. And when they're managing their own healthcare dollars, they're spending their own money rather than someone else's money. Under the third-party payer system, insurance companies or employers or government pay all the bills. And if someone else is paying the bills, we're not going to be careful consumers. We're not going to worry about costs. Our incentives are to be very wasteful. And over on the provider side, on the doctor's side, if Blue Cross is paying all the bills, the doctor tends to look to Blue Cross to decide what to do. These incentives are distorted when a third party is paying the bill. The patient's incentives are distorted, the doctor's incentives are distorted, and we get lower quality care and we get more costly care. So you empower the patient and the market changes. If you look everywhere in healthcare, it seems like the market doesn't work very well, except in those areas where there are no third-party payers. So show me a medical market where there's no Blue Cross, no employer, no Medicare, and it probably works pretty well. And one market that comes to mind is a market for cosmetic surgery. We pay for that out of our own pockets. The demand for that, those kinds of services have really soared in the last 2 decades. There's price competition, there's quality competition, and the real price keeps coming down, even as the price of every other kind of surgery keeps going up. Another area is LASIK surgery. Here again, we're paying with our own money. We have price competition, quality competition, real price going down. Those are examples of medical markets that work really well, in contrast to everything else that's happening in healthcare.
Well, you put at least four massive topics in play with that brief little soliloquy. I want to kind of unpack some of those. So the first one you talk about, of course, is price, and we can move past that one kind of quickly. But there are a couple of others that you talked about that I think are really important. One is what I call the duty of loyalty. Who is the true customer of the provider and who works for whom? And so I think you correctly point out that when the doctor is being paid by the insurance company, that the insurance company imposes regulations that I call them commercial regulations that inform the way that doctor provides care to the patient. That disintermediation, in other words, the way that the insurance company kind of gets in between the patient and the provider, has a potentially adverse consequence to the patient, doesn't it? It certainly constrains the relationship between the doctor and the patient.
Yes, and this can happen even when everyone's acting from good motives. Blue Cross has it's an obligation to its policyholders to make sure money isn't wasted, because if money is wasted, everybody's premiums rise. And so Blue Cross questions what doctors do, what hospitals do. And the doctors and the hospitals know that if they run afoul of Blue Cross, they may not get paid. And so what Blue Cross thinks should be done is very, very important, a lot more important than what the patient thinks should be done. So again, the real client in a third-party payer system is the third-party payer. And the doctors and the hospitals and other providers look to that third-party payer in deciding what to do, what drug to prescribe, whether to admit to a hospital or not, what to do once you're in a hospital. We the patients, are not the clients anymore in this kind of system.
Well, I think that there's another component to this too. When you just on your point about whether or not to admit to a hospital, it's also which hospital to admit to, right? Because some are in network, some are not. There's an economic incentive not to go to out-of-network hospitals, and an economic incentive to go inside in networks, which creates a whole litany of challenges. The issue, I think, is the question of how the patient defines price, meaning the amount that the patient pays out of pocket or as a copay or as a deductible. And they're constantly doing end rounds to try and avoid those costs, if you will, because that's the way they perceive it, not understanding that the price is actually the combination of what the insurance company pays and what the patient pays. So I think that kind of goes to your issue around incentives. I think there's another component to this too, which is as the patient is trying to decide what to do, they're not educated as well. So on the one hand, they're not making risk-based decisions because they're not able to evaluate what the alternatives are. What they're really focusing on is the out-of-pocket costs for whatever is being advocated. Would you agree with that?
Yes, in the third-party payer system, price almost has no meaning, because when we go to the doctor's office, we typically don't know what the price is going to be for anything that's done. And that's especially true in hospitals, where at the time of that we leave the hospital, we see some lengthy bill that's very, very difficult to understand. And going into the hospital, nobody tells us what anything is going to cost. And what all this really means is that unlike a normal market, in this market, the providers do not compete on price. And by the way, when they don't compete on price, they don't compete on quality either. Now, you mentioned a little bit earlier the ability to go to a hospital may be constrained by the third-party payers. And that's especially true under Obamacare. Under Obamacare, there's been a race to the bottom. And the plans that succeed look like Medicaid managed care with a high deductible. And here in Dallas, where I live, you can't buy individual insurance that will get you into UT Southwestern, which is probably the best medical research facility in the whole world. They won't take you. Down in Houston, MD Anderson Cancer Center is one of the best cancer treatment centers in the whole country. They won't take you with Obamacare insurance. And we see this around the country. This race to the bottom in terms of quality and access to health care means that people with Obamacare insurance are often denied access to the best doctors and the best hospitals.
It seems to me that the pricing models are also inequitable in that they treat humans differently, right? So the price that you would pay, for example, under an insurance plan versus a Medicaid plan are going to be wildly different, and yet again different under a Medicare plan. So it seems to me that there's a dehumanization in that. And if I'm a person on Medicaid, I would say, well, why is my pain or my injury or my illness worth less than somebody else's? It seems to me that that's a dislocation in our market. Am I mistaken there?
Well, if you think about a doctor's office, primary care doctor, he's getting paid by a lot of different payers. You mentioned Medicaid. There can be different employer plans, the insurers, Blue Cross, Humana, others, United Health. And there tends to be a different rate paid by every one of them. Now, why you should care as a patient is that if you're in one of the plans that pays a really low rate, you'll be one of the last ones the doctor wants to see. So it used to be we said Medicaid was the lowest rate paid. So the Medicaid patient has the hardest time finding a doctor who will see him. And when he finds one, he'll typically be the last in line to see that doctor. Now we have Obamacare, which in some cases is even worse than Medicaid because they tend to pay Medicaid rates, but that's combined with managed care. And what I mean by that is there's some likelihood the insurer will argue with the doctor and not pay the bill. So that's the patient the doctor wants to see last. So all this affects access to care. And, the average wait in the United States to see a new doctor is 3 weeks. But if you're on Medicaid or you're on an Obamacare plan, it can be even longer than that. This is not what I would call universal access to care.
So it seems to me that we would agree that third-party payer systems fail everyone, perhaps except for the insurance companies, because they fail the patient in terms of precluding them from access or creating a barrier to access, certainly being expensive. They create a tremendous amount of risk for doctors because not only do doctors have to do follow-ups and they have a claims process that they have to go through, their cash flows are challenged by virtue of the delays that insurance companies have in paying them the bills. They have civil and criminal risk by virtue of the codes that they may enter incorrectly or correctly, as the case may be. And so the model seems to only really work for the insurance companies. And I don't understand how, well, I guess I do understand how insurance companies have gotten so powerful, but the real question is, how do we move away from this model? One thing is obviously HSAs, which you put in place with President George W. Bush back in 2003. Talk a little bit about that process and how you were able to navigate that into legislation.
Well, to back up a bit, I wouldn't say it only works for the insurance companies. What I would say is that everyone in the system faces perverse incentives because no one's looking at real prices. No one faces the incentives that you would face in a normal market. And so over on the provider side, the incentive is to maximize against whatever payment formula the third-party payers are using. So you start with Medicare, and then many private insurers take Medicare and follow their lead. But the incentives are to do what you get paid to do. And that's why when you go to a doctor, there are lists of things that Medicare pays the doctor to do. Actually, there's 7,500 tasks that Medicare pays doctors to perform. But until recently, the telephone wasn't on the list. Email wasn't on the list. Zoom and Skype weren't on the list, so you didn't get those services. But there are other things that aren't on the list, like helping you find an inexpensive CAT scan or MRI scan, or helping you decipher what drug would be best for you to take. Patient education in general is one of the things that Medicare doesn't pay doctors to do. So this is the worst way to pay any professional. If you paid a lawyer that way, your odds of being convicted in a criminal trial would go up a lot. So you don't want to pay professionals by task. Doctors, accountants, other professionals, either they get paid one lump sum to do something, or they get paid by time. And the way we pay doctors and the way we pay hospitals greatly distorts the incentives they have and the way they practice medicine.
So circling back, you observed this long ago, and you then set about creating the models for HSAs. Talk a little bit about how you got that through the administration to adopt that under George W. Bush, and then finally got it into legislation.
Well, this started a decade earlier. And in the early 1990s, I went to Washington, and there were only a handful of members of the House of Representatives who even wanted to meet with me and talk about health savings accounts. But they did, and they introduced a bill. And then Pat Rooney was the chairman of Golden Rule Insurance Company, which was a small insurance company that sold individual policies around the country, much, much smaller than United Health and Blue Cross and the really big ones. But Pat loved the idea of the health savings accounts, and he and I together convinced more people in Washington that this was a good idea. We were very careful to make it bipartisan. In those days, this was not just a Republican idea. We had Democrats supporting it. And we got a pilot program. And it was in the mid-1990s. And then at the time George W. Bush became president, about 10 years later, we got the full health savings accounts available to everyone. In the early days, when I first brought the idea to Washington, every interest group was against me and against the idea. And that includes the American Medical Association, it includes business, it includes the Business Roundtable, the Chamber of Commerce, even small business, that we didn't have one friend in Washington. But a decade later, everybody decided, nothing else is working. Maybe we ought to try these health savings accounts, try to get the patient on our side, give people economic incentives not to waste money. And by the end of the decade, we had won almost everyone over. There was no major interest group that was opposed to health savings accounts at the time they became available nationwide.
What was the argument against health savings accounts?
Well, it wasn't their model. Their model in those days was the HMO model. You give all the money to the insurance company, and the insurance company manages your care. And patients, they believed, by they I mean the employers, the insurance companies, everybody who was paying bills, that patients could not make wise decisions on their own, that what patients thought was irrelevant, and that they and the medical community would decide what should be done in the face of various diseases and illnesses. And that was all you needed. And that turned out to be a bad model. And when they all realized they weren't saving money doing that, then all of a sudden the health savings accounts began to look attractive. By the way, there are 26 million people today that have a health savings account. And there are an equal number that have something called a health reimbursement arrangement. And then there are another 30 million people who have something called a flexible spending account. And so we have about 80 million people with some kind of account. And one of the things I think we need to do legislatively is combine all of that, make it really easy for people to have one account that's easy to obtain, easy to manage, and that fits with any third-party insurance.
Well, I completely agree with you. And I guess I'm troubled by the fact that we don't have more flexibility in the HSAs, even as they stand today. For example, you can't leave it to your heirs. You can only leave it to your spouse. And there are limitations on how much you can put in, and there are limitations on what you can use it for. It seems to me that we ought to be encouraging people to put more money, if they can afford to do so, into HSAs, so they have more flexibility in their premium payments, because they're first risk, and that way they ought to be able to create more savings by managing their spending better. But I don't see that happening. And it feels to me like the insurance companies increasingly encourage people to treat health insurance as a layaway plan for health. It's not really health insurance to provide against financial catastrophe. It's instead a layaway plan so that somebody else is responsible for your health care. And so it frees the individual to make good and a lot of times bad decisions around their own health care.
Well, back in the beginning, we were accused of creating an account that benefited the healthy. And it's certainly true that if you are healthy, if you never see a doctor, the health savings account is probably the best savings account there is. It's better than an IRA, better than a 401k, and we can go into some of the reasons for that. But it's a wonderful savings account. But what we overlooked was that this could also work for the chronically ill. And right now, it's not designed that way. If you put $3,000 into a health savings account every year and you're diabetic and you spend that much on diabetes, it's just money in, money out, and you haven't accomplished anything. But 70% of the money is going for chronic illness. And studies show that chronic patients can often, with some training and education, manage their own care better than traditional doctor care. So my argument is, well, if we're going to let them manage their own care, let's let them manage the money that pays for that care. And then if they comply with their drug regime and they make intelligent decisions and save money, they get to keep the money they save. And so we could change overnight our treatment of chronic illness and have better outcomes and spend less money if we would be creative in using these accounts for that purpose. But we need Congress to allow us to do it.
Who do you see on the Hill as particularly a strong advocate for the work that you've done on HSAs and the expansion of the utility of HSAs you'd like to see happen?
Well, on the Republican side, almost everybody is for the health savings accounts. On the Democratic side, it's not. Some are, but there's not the same degree of enthusiasm. But I would say most members of Congress don't understand these accounts. What I just said about their use for chronic illness, almost no one in Congress understands that. The attention span of a normal member of Congress is really quite short. And I'm sorry to say that both Republicans and Democrats do not understand the healthcare market. And they have been unwilling to take the time to understand how the market works and how it doesn't work, and how empowering patients could make it work so much better.
It's astonishing to me that such a large piece of our GDP goes to healthcare, and yet we don't have more focus and more attention on it from the legislative bodies of the country. It's not just the federal government, but also the state level. A friend of mine who ran for Senate said to me once, he said, his greatest disappointment in running was realizing how little people understood on the Hill about economics. And coupled with that, I guess, would be their unwillingness to learn. It's not, I don't think, terribly difficult, but until you get into some of the work that you've done, which is very complex. But I think the idea that legislators need to embrace this and really work towards solving the problem by creating health savings accounts and other kinds, so that people can save money on their own and build value and wealth is critical. We have to kind of revert back to some of the principles of the country, which are, we want to see mobility between the classes. We want to see people improve their lot of life and gain economically. And I think healthcare is an area where, unfortunately, we're not seeing that kind of progress be made.
The best example of a politician who ignored healthcare at his peril was Donald Trump. Under Donald Trump, we had amazing deregulation of healthcare. Most people don't realize it, but as we entered the healthcare market last year, a senior could not talk to his doctor by phone or by email. Even young people could not use Skype or Zoom the way we're talking now because it violated privacy rules. Well, the Trump administration had been working from day one to liberalize healthcare. And so when COVID came along, Congress gave the president temporary authority to set aside congressional restrictions. And just almost overnight, every senior on Medicare could suddenly talk to the doctor by phone, by email, by Skype. By April of last year, just 2 months into the COVID crisis, 1 in 3 seniors in the cities had at least one telehealth visit, and 1 in 5 in the rural areas. And this is the least computer literate group in our society. So Trump did this and so many other things, the vaccine, the warp speed. But when he ran for re-election, he didn't really mention any of this. He should have held up the phone and said, look, because of me, you can now talk to your doctor by phone. I think if he had done that, I think if he had run on the deregulation and the improvements he had made in healthcare, or that his administration made, he might have won. Because I think that was his one big weakness in running for re-election.
Well, you're spot on. I mean, not only did he completely renovate or change telemedicine, but he also went a long way for pricing transparency with big pharma and price and drug purchasing power, and a whole litany of other things that he didn't get any credit for, nor did he raise to his own demise. Unfortunately, you're right. He did a lot that people just don't realize.
There's one other thing you didn't mention. As of January 1st of a year ago, employers can now buy insurance for their employees that they own and can take with them. Now, under the Obama administration, this was not only discouraged, there was a huge fine. If an employer was caught buying insurance for an employee that the employee owned, in other words, if the employer bought Blue Cross individual insurance for his employee instead of Blue Cross group insurance that the employee has to give up when he leaves the group, the fine was $100 per employee per day. So the Obama administration really didn't like this idea. Trump completely reversed it. In both cases, Congress didn't have any say in it. This was all by executive order. So as of January 1st of last year, the employer could do this. It has to be Obamacare compliant insurance, but still, if that market improves and becomes more attractive, employers will be able to buy individually owned insurance. I call it personal portable insurance. And when you've got a pandemic that's making everybody sick and businesses are closing, that's the kind of insurance you want. You can be laid off, you can lose your job, but you don't lose your insurance. And Trump should have campaigned on that. He should have said, this is what I did. I spent, by the way, it took more than a year to get that executive order finally approved. And so many man hours went into getting that done. And it's almost like he wasn't even aware of what he had done.
Yeah, or the impact, the magnitude of the impact. It was enormous. And so just to follow on that point, it's the portability issue is enormous as well. And the fact that it would have been so much less expensive than Cobra, for example, is also helpful to the individual. So it's, some of these things are just illogical when you kind of separate them from the dialogue to really look at them independently and say, why would you do that? It just doesn't make a whole lot of sense to me. And a lot of people, obviously not to you either. So I'm grateful for that. I'm grateful that you would stand up and say, hey, this doesn't make any walking around sense, as we say in Texas.
Yes. Trump, what I think made all of this possible is that Trump financed his own campaign. And you mentioned earlier how much we're spending on healthcare. It's about 1 out of every $5 of national income. And so when you have that much money going into a market, you have every part of the market that's getting a portion of that money in Congress, calling on congressmen every day. The life of a typical congressman, they're seeing lobbyists all the time, but they see healthcare lobbyists more than any other kind of lobbyists. And Trump was able to appoint people who carried out deregulation of healthcare, and he didn't seem to care whether he made people mad. So he was sued by the hospitals, he was sued by the drug companies, he was sued by the insurance companies. He could easily have been sued by the doctors. He didn't seem to care who sued him. He would just do these things by executive order, and then there would be court cases. But I don't think another Republican president would have been able to do it or would have done it. And the sad thing about Trump is I don't think he, even today, realizes all the good that he did.
Yeah, he could have certainly campaigned on issues differently. And it's unfortunate that a lot of these things have been or will be or have been already overturned by the current administration, because it seems like anything that Trump did is inherently bad by the current administration. It doesn't seem like there's a proper review.
Operation Warp Speed. The University of Chicago economists estimate that getting those drugs to market 6 months earlier than anybody thought was possible. And that was possible only because of deregulation of the drug market. It was worth $1.8 trillion and saved more than 100,000 lives. So this is incredible. And not only did Trump not campaign on that, no one in the Biden administration is giving him any credit for doing any of it.
Well, there's another piece of that story that's a little bit unheralded, which is the work that Senator Steve Daines did, the junior senator out of Montana, who got the federal government to cover the cost of the manufacturing runs in the event that the drugs that were under testing did not reach or receive FDA approval. So they accelerated the manufacturing capability of the providers. That was part of Warp Speed, but had Senator Daines not undertaken that effort, I think it would have delayed the rollout substantially because we would have had to wait for the FDA trials to be successful.
Well, another thing the Trump administration did was when Congress wouldn't fully fund Operation Warp Speed, he scavenged money from other budgets, probably exceeding his executive authority. But in any event, he did it and made the money available. And had he not done that, we wouldn't have had those drugs as quickly as we have had them.
John, thank you once again for all the work that you've done in this field. Consumerism is the basis for the work that I put together in the 60% Solution, the book that I've just released. I really build on your work on HSA specifically. Like many, I consider you the father of HSAs, and I think the work that you've done is important for the American people. I've tried to address some other issues with regard to regulation, around licensing, cross-border issues, and the like. And I've also tried to employ a systematic approach to healthcare by addressing issues around pricing and accounting and IT work, because I think those are other problems in the field. But none of this would be possible without your foundational work on HSAs. So I thank you for that, for myself and for the American people. And I'm really grateful for your time this morning. I hope you'll consider being a guest again. It's been a delight speaking with you. And I'm really, really looking forward to moving the industry forward based on your work.
Thank you, Todd. Glad to be with you.
Thanks for watching this week's episode of Civil Discourse. To learn more about today's topic or our guest, visit www.the60percentsolution.com or www.tfip.group.